First off, what principle in life do you hold?
Do what is right.
If you weren't a doctor, what career would you have pursued?
I would have been a pilot because once upon a time I wanted to be a pilot, but obviously the path is not there for me to, to ride on. Yeah.
That's pretty cool too, and I think Malaysia is actually pretty lucky you didn't pursue that path. If you had an extra hour in a day, what would you do with it and why?
I think more important now that I retired, if I have extra hours, I would spend with my family. That's all. Yeah.
Yeah, family first, right? Yeah, above everything. And finally, what's the best advice that you've ever gotten?
I think the best advice is to be honest and sincere when you are dealing with patient or public. Right? That's the key. To make a big difference in terms of engagement with the patients and public.
Yeah, and I think that is definitely a principle that we all saw during the COVID years. During the COVID years, of course, it was a huge crisis. And so crisis communication is crucial in public health as we witnessed. So how did you approach delivering complex medical information to the public while maintaining trust?
I think today we have social media. More important, I think, you must read the social media as well. Not necessary to respond, but to read. At least you know what people are talking about, what are the issues and challenges out there. Once you read it, then, you try to analyze it. As Einstein said, if you need to solve a problem, in 1 hour, 55 minutes will be used to understand the problem first. 5 minutes is to solve the problem. So the key is to understand the issues, and what people are talking about. Once you understand it, then you know how to solve it.
Speaking about that, because we know that social media was used rampantly during the COVID-19 era, and so misinformation, disinformation was also spreading like
wildfire.
It was the other viral infection. Yeah. So, and therefore, what role do healthcare practitioners as well as policymakers have in order to straighten this out, basically?
I was lucky because I started social media very early, 2013. The reason I use social media is that there's a perception that, DG have a big office, stay in the office and etc., not knowing what we do. So social media, platform is engaging with the public to show what we do every day. You see, so it's a double-edged sword. You talk about work rather than talk about yourself or your food and etc. But it's more engaging to tell them what we do, and because of using this social media, and then you engage with the public using social media. Explain the issues and challenges, and then especially the misinformation and disinformation, and then you can actually clarify it. Once you have done that, you manage the expectation of the public. So if you can manage the expectation of public, you win the public trust. So that's the key. And use facts, science and data to explain, not your feeling. It's not you, but it's more towards data available. Because in this day and age, data can be referred to very easily using a computer and etc., using the internet. So again, this is the key, how we engage with the public and to build trust. And that is where I think, that helps a lot. Once you have that in hand, and even the reporter need not come to me face to face. They go to the social media and they read. Every day without fail, there will be upload on the social media regards to the pandemic COVID-19, the do's and don'ts and etc. So that's how we manage to use and capitalize social media, optimize it, and to be more efficient in the way we manage the COVID-19.
So in other words, to use social media backed with data and information instead of being very emotionally charged in order to spread, information, but also using data to capture a certain emotion, which is trust among the public. Is that right?
Yeah, I mean, social media, you can also show empathy in your social media. It's not a robot writing without feeling, but you can actually, when you write, the public can feel you. It's just like you reading a storybook. Sometimes you feel and you can cry just reading a storybook.
Indeed, yeah.
So likewise, you do it yourself, I do it myself, because I do not let other people use my social media to upload all the information. I've been offered, obviously, from companies and etc., to use my social media for advertising and etc. And I don't allow others to upload information in my social media, because if it's a wrong messaging, I will be responsible, not the person. Obviously, they can help me to get the data, but I have to read the data, digest it, and then I think it's right, then only I upload in social media.
Yeah, for sure, because anything that is uploaded from your account,
Yes.
people would take it as it is your words
That's
and
right.
your emotions, it's your message
That's
to
right.
the public, and
That's
whatever that's on social media stays in social media in the internet world forever.
Yes, right. That's
Yeah.
right.
So moving on to a slightly different topic, there's this issue of conflict between insurance companies
Yes.
and private healthcare providers as well as
Right.
patients
Right.
due to rising costs.
Right.
Basically, so with this increasing complexity in healthcare financing, ranging from insurance claims to rising treatment costs, what do you see as the key challenges in creating a fair and sustainable system for all stakeholders?
No, healthcare cost is not cheap. Let's put it that way. Let's look at other countries and etc. Healthcare cost is not cheap. In the public sector, it's heavily subsidized by the government. In the private sector, then it has to depend in terms of how do they charge, and all been regulated, especially the professional fee, been heavily regulated. Over the last 20 years, we have seen the escalating healthcare costs. Why? One of the reasons is maybe also associated with the geopolitics, for example, depreciating ringgit, our medicine, our medical devices, and etc. has actually gone up. But we are not able to catch up. More importantly, so we have to accept the fact that the price of healthcare costs today and 20 years ago is different, right? Likewise, the inflation for other food and etc. is the same. We have to accept that. Now is the question of how do we strike a balance in terms of fair pricing. That is the whole big issue now. How do we come up with a fair pricing? So now, if we accept the fact that the healthcare cost is escalating, only in terms of the fairness in the pricing, and some of the pricing that you look for the last 20 years has not been reviewed, the cost of the healthcare. For example, in IJN, the fee for IJN, more than 20 years have not been reviewed. Meaning, if you do the operation today, you've been charged the fee 20 years ago. Likewise, also the fee schedule under MMA, the last one in 2006. So almost 20 years now, coming to 20 years, close to 20 years now, not been reviewed. So you name me one thing that you buy today at the cost of 20 years ago, right? So we have to accept that. Now, only thing being questioned is whether there is abuse in charging, right? So you charge unnecessary. If it's a fair pricing, I think it's good, right? It's a fair pricing, and then especially professional fee. Professional fee been regulated since 2006. Been regulated. We can't charge more than been stipulated in the fee schedule, so it's been regulated. But the non-professional fee is not being regulated, and that's hospital beds, food. These are all non-professional fee. Perhaps we need to review in them, and the non-professional fee is depend on where you are, right? In KL, it will be more expensive as compared to in the rural areas, for example. So things like this. And the other thing is we look into MCO, managed care organization, whereby companies, for example, they do not want to go through to manage the expenses or expenditure of the healthcare. So they assign to a MCO. MCO look into it, and then there will be a fee being charged, whether the fee is reasonable or not. And secondly, it's not regulated. You see, so maybe we need to see how we can regulate the managed care organization so that the range that been charged been accepted by all parties, by the patient, by the insurance company, and these are the things. How do we strike that balance now in terms of a reasonable, fair pricing for the patient paying the premium and the insurance company, not overcharged by the insurance company, so we know what are they covered for. For example, if you take insurance cover, you must know the details, what you're covered and what not covered. And as well as the MCO, how much they are taking in terms of, charging for each patient, for example. And also the doctors and the hospital. As I said, the doctors, I'm not worried because there's already a regulation. You can't charge more than been stipulated in the health fee schedule. But the non-professional fee, you certainly can look into it. And the charges now that I'm in private sector, majority of the charges is non-professional fee, not the professional fee. Sometimes professional fee is about 10% or even 15% of the total fee. So I think you must look into it. But the public perception is the doctor is charging everything, right? It's not. The doctor charge only the professional fee. The non-professional fee charged under the doctor, but is under the hospital.
So it is really actually the non-professional fees. So I suppose that would be like the food and the gloves and all these additional charges, which...
But we also need to review the Fee Act, for example. I mean, if 20 years have not been reviewed, for example, I think it's about time for us to review. How long do we want to postpone, paying the fee to the doctor as 20 years ago? So I think this is a real concern. In IGN, it's the same thing. In the private GPs also charging the same. The fee has not been reviewed. I think what is more important to strike that balance for a reasonable, fair pricing of the medical fee.
And so, because to a lot of the general public, they would feel that medical inflation is actually outpacing general inflation. But of course, there's room to debate on that. Tapping on your point earlier that the fee schedule has been the same for over 20 years. But should Malaysia explore options like mandatory health insurance or a national health fund to enhance affordability and coverage?
I think Malaysia, we continue to, we continue to provide one of the best healthcare in the country in terms of affordability, high impact, reasonable outcome with good outcome with reasonable cost. That's what we try to balance now. So now there's actually blaming game. Insurance companies say that it's high healthcare costs escalated. They blame the MCO, they blame the doctor, they blame the hospital. We need to sit down together, in the organization representing the insurance company, representing the hospital, the professional, the MCO. See how to strike that balance. How to have a fair pricing that's acceptable to the public as well. So I think how to strike the balance is the question. That's the key. Do we need to regulate? So if there is abuse, obviously regulation comes in. But we do not want to be over-regulated until you impair in terms of the quality of care and services. So I think we need to be reasonable in terms of how we can come up and justification. As I said, healthcare costs has increased over the last 20 years, but the fee schedule is still the same. But perhaps the non-professional fee has increased. Perhaps the MCO charges also have increased. Perhaps the claims also have increased. So again, how do we justify it? And we also need to look at the professionalism of the doctor, whether they are charging the right thing. They don't abuse in unnecessary charges, for example. So then there must be a mechanism of monitoring in place. Looking into the data. Now we live in the world of data. Everything can be traced, can be tracked. And that's where we need to look at a system that can strike a balance and in terms of affordability, equity, and quality of healthcare costs.
Well, and in this case, because when we look at other countries like Australia, and then they have their national healthcare insurance, and then so like payments are made directly from there. Do you think this would work?
We have been discussing over the last 40 years about healthcare transformation, but we need a strong political commitment and will to implement it. And this is not a short term, this is a long term. But unfortunately, government comes and go, and it's not easy for the government to implement, because unless you have a strong political will to do so, whether you can do it or not, because this is, you have given everything to the patient, and then suddenly you need, if you do piecemeal adjustment here and there, for example, patient has been charged 1 ringgit, then you piecemeal, you increase to 5 ringgit, and etc. That is not going to solve the problem. You need to have the overhaul of the whole system, but you need to have a strong political will to do so. So if you have a strong political will to do so, and then perhaps we can implement. That's the reason we mooted the idea of the white paper, because the new government comes in, they will negate what the previous government have done and try not to follow through, and then they will try to do their things, and the next government comes in will do the same, right? So if it's a white paper presented to the parliament, tabled to the parliament, and you get a bipartisan support, meaning opposition and the backbenchers and government of the day agreed to this principle, regardless who is the health minister, regardless which party is ruling and who is the government, you continue this white paper that has been approved in parliament, for example. So then you can see the long term. We need to plan for long term implementation. We were the first few that actually visited Taiwan to learn about health financing, but until today we have not implemented it. Indonesia were very recently they were into the health transformation and health financing. They already implemented it. The issues that they have, and we also understand, is in terms of the subscription again, how much that you need the quantum for a different category of population, how much B40, how much M40, how much T20, and etc. But we think that you can do it under employment health benefits. So if everybody is employed, then the employer will be tasked to look into the health benefits as well. But what about if self-working, for example? So you must have a mechanism in terms of maybe tax reduction or etc. And then that reduction goes to the health financing. It's just like how many percentage goes to the health financing, and then that will provide the coverage. And that coverage you can access to treatment in public sector and the private sector. And that's how I think in a bigger picture. But I think the most important today is the political will and commitment.
Yeah, because it would not only involve just the health ministry, it would involve a lot of other ministries, because
right.
If we were to have a national medical health insurance, that would also probably mean that taxes would go up.
That's right.
Yeah.
So additional taxes, for example, if our taxes are certain amount, then probably a few percentage will go to the healthcare system, right? Health financing system. Maybe that's just what been done in UK. Apart from their general taxation, so they also tax for the health coverage and etc.
So, if that's the case, because we're sort of stuck in a conundrum like this, but like what sort of substantial initiatives do you think or improvements would you suggest to enhance patient protection?
So I think we encourage now, for example, all the documented migrants, they have insurance. Obviously, non-documented is non-documented, they are not included, but documented, they have insurance. And then we encourage insurance, maybe through tax rebate and etc. We encourage individual now to have their insurance, but the policy must come from the government, in terms of to support this and have a political will to make a big difference, to ensure that everyone is insured. If everyone is insured, then the patient have the choice whether to go to public sector or private sector because he's insured. So if the service is good in public sector, they still go back to public sector. If the service is good in private sector, they still go to private sector. So at least they crisscross between public and private. This is what we learned from pandemic COVID-19. Leverage on the experience, whole government and whole society approach, right? So you come together, so cases can be referred to public or private. Even now, I think we try to solve the problem of congestion in the public sector. The government allocated a certain amount of funds to outsource some of the patients to the private hospital. Like for example, in cardiac surgery, because there's long waiting lists, I heard more than 700 people are waiting in the public sector. The government is really outsourcing to the private hospital to clear some of the cases. Otherwise, I heard 10 to 15%, will succumb to the illness before they get the surgery. I think this is how we can actually, but government is not the insurance company, right? Government have a policies, but make sure that everyone is insured, whether it's from the health financing or whether it's a private insurance, public insurance or private insurance. QPACs have their own insurance, for example, so we can actually encourage insurance, public insurance, private insurance. Now, if they have a public insurance coverage and then they have additional private insurance, that will give them better coverage in terms of facilities, in terms of better environment, in terms of when we go to the private hospital or even a public hospital. So they have the two insurance, public and private. So that would be good in that sense. I think we need to invest in our health, and the only way to invest, maybe government can give a rebate, for example, from the taxation. That also may help. So I think we need to think through and see how best we can come up with a mechanism to actually cover our population, not only for documented migrants but also for our locals.
Yeah, certainly, like you mentioned earlier, if there's a crossing between the public and the private healthcare, I feel definitely lighten the burden of public healthcare.
Right.
But also, yes, what you mentioned earlier just reminded me of the issue of the documented migrants and the undocumented migrants issue during the pandemic. And then there were people saying that, but undocumented migrants are also human beings, so how come they don't get the similar health care as documented migrants, even though everyone's human being?
Well, during the pandemic, we treat everybody the same, documented or undocumented. In fact, undocumented, we use a one-shot vaccine, like CanSino and etc. So one shot. So we're not sure we're going to see them again. So documented is different. You know where they work and etc. They come back for the second dose. So I think, regardless of infectious diseases, for example, regardless documented or non-documented, we try our best to cover for them, but there's a certain amount of cost. So what we mooted in the past is that, if it's undocumented, and then we try to work with NGOs and international organizations to procure a reasonable cost of the vaccine for them, right? And then, or treatment for them. And then for local or documented, then it will be follow the normal procurement of the vaccine. But if it's a special procurement, for example, from the NGOs, international NGOs, then probably they can cover for that group of patients.
Mm-hmm. So, looking ahead, what would be one major healthcare reform that you would hope to see?
I think certainly we look into the financing, right? Financing is very important. How do we integrate the public sector and private sector? So if we have a health financing in place, then we can integrate. Like during the crisis, we are working with public sector and private sector. Non-COVID cases we send to a private hospital, COVID cases come to public hospital. So we work very closely. And in fact, more than 2,000 staff from the private sector crossed over to public sector pro bono to assist us. So you can see a close collaboration between the two. So to bridge this gap, I think we need to address the payment in terms of who is paying. So if we have a national health financing, cutting across public and private, we can also help to decongest the public hospital. And if you can actually push the quality of care, if the quality of care is good in the public sector, they still go back to the public sector. If the quality of care is in private, obviously they go to private, but they have access. Now the rich have the access to public and private. You can't deprive the rich to come to the public hospital because they are the one that pay the income tax. But if the service is good, they still come to the public hospital. But the poor have no access to the private hospital. They only have access to the public and the long queue there. So I think this is how we strike that balance to optimize the resources in the country, in terms of human resource and beds and etc. So if we can integrate the two, that would be the best, of course.
Yeah, and now that you have retired from civil service from the public healthcare system and you're in the private healthcare system now, so you have the eagle eye view of both. What advice would you give to young medical practitioners now?
Yeah, I think you have to serve the government. I mean, it's a social responsibility. I have done that. I've served the government for 35 years. That also gives you the experience, knowledge, and obviously seniority. And not only serving, not in providing healthcare, but also you have an opportunity to train, to educate people, doctors. And also more important is the platform to do clinical trials and research. And in the public sector we have all kind of cases, case mix is available, and that enhance experience from time to time. So in the private sector, if we can actually continue to provide services, provide training and education, and more important, we also have to do clinical trial and research as well. So that will justify in the role of the private hospital. What I need to see is the integration between the public and private. So we look at optimization, because remember, once they retire, they still can practice about less than 5 to 10 years. If they cross, I mean, all senior consultants are in the private sector, but they are not being used for training, research, and etc. That will be a waste. So why can't we use them? This is where we try to optimize rather than sector. We look at the country needs and demand. So we need to fulfill the unmet needs of the country. So this is something that doable, and this is why I think in private sector, when I came to private sector, we started the public wing. In the public hospital, we have a private wing, right? In the private hospital, we have a public wing. It's actually basically we're trying to subsidize as well to help the patient that have been referred from the public sector. So the integration, if we can integrate, then we optimize the resources in terms of research, training, and providing the services.
Yeah. Thank you very much for speaking to us
No
today,
worries.
Doctor.
More than happy to do so.
Yeah, I mean, just looking at your face basically brings back a lot of memories of during the COVID years, and I'm sure during those times your calm demeanor reassured the entire country of our situation back then. So thank you so much to you and your team back then. So thank you so much.
Thank you.
Again, I've been speaking to Tan Sri, Dato Sri, Dr. Noor Hisham Abdullah, former Director General of Health Malaysia. This is Spill the Teh, a podcast by Penang Institute.